Okay, thank you and good morning everyone to today's Journal Club. We've got two, again, very interesting talks for you today. Our first one, thank you to Jason Trubiano for coming all the way from the Austin to give us a talk on antibiotic allergy, which I'm sure everyone is very keen to hear about. Lots of news floating around in the journal sphere at the moment regarding this. So it'd be really good to hear some Jason's thoughts on this, and thank you, Jason.
Okay, thanks very much for the opportunity. It's great to be here talking. So I'm going to focus today on evidence that you may use in a document in your hospital, healthcare network, community service to try and build an antibiotic allergy program. I'm going to focus less on the actual the interventions and more on the evidence base for why we should think about incorporating this into AMS programs nationally. So it is Journal Club, so I thought I'd start with a journal, and this was an article that recently came out in BMJ. Interesting, they spelt methicillin incorrectly in the title, which I found interesting. This was an article that used UK data, actually community-based data, to look at the impact of penicillin allergy on the acquisition of MRSA and C. diff infection. And the power was in their study numbers. They had 64,000 patients in this community-based database, and they were able to track patients when they evolved their penicillin allergy and also their MRSA and C. diff status. You can see here from allergy types, a fair proportion of those were still intolerances, and they've listed allergy, and I'm saying in inverted commas for those online. You don't really know what that allergy listed is. But the take-home message really was that the risk of antimicrobial resistance in penicillin allergic patients was significant when they looked at these two bugs, MRSA and C. diff, and certainly antibiotic usage in penicillin allergic was also impacted, particularly with two of the C's, clindamycin and fluoroquinolones. So the article is similar to what the US have also talked about this in the past. The US likes showing data about MRSA infection with penicillin allergy, and their epidemiology is different to us, but we have limited data in Australia looking at AMR and penicillin allergy. Again, this has the same kind of issues. It's association level data only. I'm not sure it typically applies to an Australian context where our MRSA and C. diff rates are different, but the scientific link is plausible. I guess you've got a penicillin allergic patient using antibiotics to drive the acquisition of these organisms. So there is a scientific plausibility, but I don't think it necessarily applies to us completely. I'd like it to be. I often hear that antibiotic allergy is the low-hanging fruit, and I'm not offended by that. I think it's true. It's something that in lots of respects, every person, clinician, nurse, pharmacist can address in some way. So I think it is a low-hanging fruit, and that's a good thing. And it's a low-hanging fruit because even if people are labelled as penicillin allergy, it's not necessarily forever. And we know from good data that penicillin allergy is lost over time. 50% will lose their allergy at 5 years. From a lovely paper out of WA, they found that 89% of penicillin allergies could be removed by formal testing. But I do always have this word of caution that we have to be vigilant for rare but severe antibiotic allergy histories, and embedded within this large population that are not allergic and bogus, there will be a true population that we have to be careful of. And there's kind of been this call to arms for antibiotic allergy, and mainly because clinicians have been annoyed by seeing this on drug charts. This was actually a photo by Ben Tay taken from a real drug chart where the person was allergic to all antibiotics. And then the bandwagon has started with people trying to incorporate antibiotic allergy programs into stewardship. And this has come from both allergists, pharmacists, and ID physicians alike, trying to embed or make claims to use stewardship in their service. So after 3 years, I guess, of a PhD, it's a bit embarrassing when you could put most of your data on one slide, but that's the truth. And some data we did initially with NAPS data, with Carolyn and NCAS, was that we found that 18% of all hospitalised patients receiving an antibiotic will report an antibiotic allergy that impacts their healthcare. And we looked at Peter Mac and some other cancer data. We found that up to 1 in 4 cancer patients will harbour some form of antibiotic allergy. And when you look at that allergy, at an association level, it is associated with increased use of restricted antibiotics, medication costs, length of stay in AMR. And what's more interesting is that it's associated with a threefold increased risk of a further adverse drug event if somebody has an allergy. It's disappointing because we showed it up in our data that 85% could have their antibiotic allergy label removed. And once you remove that, you can increase appropriate antibiotic prescriptions by 30% and penicillin use by 15%, and particularly can induce guideline preferred antibiotics by 70%. That 70% is a bit skewed because we looked at a large population of cancer patients, and the guideline preferred antibiotic, for example, was tazocin over cefepime. So a lot of our patients were able to use tazocin on next presentations, which is still important. So if I had to break into 3 bits, I'd say, well, if we're going to build a case, what are some supporting evidence from our national standards and guidelines? What is the link between AMS and AMR? And what about outcomes and some simple solutions? They're the 3 bits I'm going to break up today's talk into. So we're doing accreditation at the Austin at this point in time. It's always a fun time. And it made me go through reading the standards again. And I'm particularly interested in the link between standard 3 and standard 4. And I think AMS has a huge impact on standard 3, so much so that we present them together. So if you look at standard 3, action is taken to improve effectiveness of AMS, yes. Standard 4, medication allergies and adverse reactions are documented in the patient medical record. These are just 2 bits taken from those. So clearly key points are we want to reduce inappropriate prescribing, reduce restricted antibiotic usage, reduce antimicrobial resistance. On the other hand, action is taken to reduce the risk of adverse events. Well, I think all 3 of these, if you do all 3 of them, you are going to reduce the risk of adverse events just by the nature of the drugs you are using. Quality improvement action to reduce risk of patient harm, increase effectiveness of medication usage. Again, I think all 3 are integrated completely with these 2 statements. So I think both AMS is integrated into standard 4, but particularly antibiotic allergy is one of those things that transverses both standards and actually could be seen as a tool to help both of those. So if we're selling it to our executives, I think this is one of the key points. So if we look at the US guidelines, unfortunately, but we look at those guidelines that were recently published, I guess, they do make comment that antibiotic allergy assessments and penicillin skin testing, PCN, can enhance the use of first-line agents, but is largely unstudied as a primary ASB intervention. This was before some of the papers that we put out and some other groups in the US, which I think has changed the landscape. But again, we've got a guideline calling for allergy assessments to be part of our AMS program. What about local guideline support? So this is the current therapeutic guidelines figure on approaching antibiotic hypersensitivity. It's buried within the therapeutic guidelines, but referred to quite significantly. But even within that buried text, there is a small call that we should be looking at antibiotic allergy or allergy testing or drug provocation under special supervision. And these kind of calls, but without any really strong statements. But again, in all allergies, in immediate hypersensitivities, in severe hypersensitivities, and delayed. So there is existing guideline support to provide allergy testing and drug provocation. And I'll talk about how we're revising that in one of the final slides. If we look at our allergy colleagues, they put out a document recently about penicillin allergy and what's contraindicated, what's cautioned, and what's considered safe. I have some issues with a bit of this documentation, but again, this sort of small line tag, seek special advice, and in tiny print, immunology consultation for formal testing and or desensitization may be indicated. It's not very helpful. So I don't think this helps us too much. But again, another guideline buried within their website underneath this document actually suggests that if treatment is definitively required, we should administer an antibiotic. And if penicillin is preferred, we should seek skin testing. And again, they have a more practical approach to delayed non-severe reactions about re-challenging. But again, a lot of this guideline stuff is buried within text, hard for clinicians to find. So I think we've got some guideline support, if we had to say to the executive, but not really a complete story. So what about AMS and AMR? Well, I've talked about that recent article in the BMJ linking to AMR. And again, this is some of our data from the NAPS data where we looked at antibiotic prescribing in those with and without an antibiotic allergy. And many of you that have heard me speak before would have seen this slide, but I think it is nice that there's an increase in inappropriate prescription in those with an antibiotic allergy. But again, the difference is borne out more significantly in those that are immunocompromised. And that's been the target mainly of many of our antibiotic allergy programs, are the immunocompromised host. And again, if you look at particular class usage, you can see in those with an antibiotic allergy, we use less beta-lactams and more of our key restricted antimicrobials that we're targeting in our programs. I haven't showed this slide before, but often people say, well, is it just a penicillin allergy that is driving inappropriate prescribing? Well, it's actually not. It's any allergy label, in fact, drives inappropriate prescribing. So it's a busy slide. I apologise for that. But along the y-axis here is the different types of allergy labels. And you can see really irrespective of the allergy label, you get this driving of inappropriate or restricted antimicrobials in the allergy group more than the non-allergy group. And when we look also at appropriateness scores within those, we can also see that for each specific antibiotic allergy, more inappropriate antibiotics are being prescribed. So any allergy label, irrespective, more than penicillin, has an impact on prescribing. So what we did on the back of this paper was introduce an antibiotic allergy testing program. And this was based upon some other data that shows it can be used, particularly to reduce vancomycin usage in MSSA infections. There's a lot of data on pharmacist referral directly to allergists to increase beta-lactam usage, and very small amounts of data of skin prick testing in the acute setting, mainly because you're worried about a false negative because they're so ill. There's been cost-saving data in penicillin allergy testing, which is great to show also in a business case. The problem is none of it is Australian data. And we really lack good health economic data in antibiotic allergy testing. It's something we're looking to do to kind of supplement all this clinical data. There's also been the integration of ID fellow and pharmacist-led inpatient testing programs. And if you look at the US data compared to ours, they really do pick the low-hanging fruit. So all their antibiotic allergy testing is primarily in patients we would consider for oral re-challenge. So their numbers are really, really good. But they've been able to successfully do that also in inpatient settings. There are barriers, and I think it would be remiss to not talk about the barriers to antibiotic allergy testing implementation. And predominantly it's resource rich. To run a clinic, doctors, nurses, pharmacy, all doing that. The reagents we use are non-TGA approved, so it needs DTC approval at an engaged hospital setting. It requires specialist knowledge in terms of skin testing. And in somebody that doesn't have that straightforward penicillin allergy, they have multiple drug allergies or non-beta-lactam allergies, well, it's much more complicated. So I think we have to be aware that not every hospital can just run and start a penicillin allergy testing program because there are these barriers to that. But if you do, well, you can have a significant impact. So this is looking at our data, comparing antibiotic usage pre and post antibiotic allergy testing, looking at narrow spectrum penicillins, narrow spectrum beta-lactams, beta-lactam, beta-lactamase inhibitors like augmentin and tazocin. And I'll draw your attention to the red box. You can see pre and post that there is a significant increase in the antibiotics we want and a reduction in the ones we don't want post allergy testing in this cohort of patients. So from 118 patients, we're able to remove 83% of allergies, and we're able to increase antibiotic appropriateness almost 12-fold post-testing, so a significant increase. So I think it's embedded in national standards, and we've got some evidence, some guideline evidence. There's a link between AMR, and it certainly helps some of our AMS key endpoints like antibiotic appropriateness. But what about patient outcomes and some simple solutions? So I tried to cram all I could find with association level data into one slide. And what we do see is that antibiotic allergies are associated with inferior patient outcomes. There's a lot of data now showing increased length of stay, ICU admission, and mortality. The mortality data and the ICU admission data comes from the US. We were able to show length of stay association at Peter Mac and another data set. So that seems to be consistent across continents and regions. There's been one paper that looked at the increased risk of surgical site infections. This was from Kim Blumenthal in the US. Again, a lot of those surgical site infections were MRSA, not typically a problem in a lot of our hospitals, but there certainly was a clear link with that, probably driven by clindamycin and vancomycin use rather than cefazolin use in the theatre setting. There is increased risk of adverse drug reactions in particular, and there was one paper that also looked at composite endpoints of drug reaction, acute renal failure, C. diff, and those three things together were significantly increased in those that had an allergy. And drug administration costs were also increased. I find this data very hard to interpret and very hard to apply in an Australian setting, particularly when Ben-Pen is more expensive than Mero and ceftriaxone. I think we're going to really struggle to build a case on drug administration costs as a sole endpoint. It's something that an executive often will ask us to put in a business case, but I don't think it's good data we should be exploring. It's more important to look at the other associated healthcare costs rather than just direct drug administration costs. People always ask about primary care, and it's a huge hole. We need better data on our primary care situation. I think it will be similar. This is one paper that demonstrated that the impacts in primary care of an antibiotic allergy are probably the same, and particularly they showed increased risk of receiving more than one antibiotic or restricted antimicrobial if you had a penicillin allergy in primary care. But a lot of our programs don't extend there. It's a huge burden and a huge problem, and probably the next step we need to take. So hopefully I can show you that the impact is clearly beyond appropriate antibiotic choice. And we certainly need in Australia interventions that show a reduction with antibiotic allergy programs, not just in appropriateness, but in these long-term patient outcomes. I think it's important. So all well and good. Can you just give me a simple solution? How can we integrate into routine AMS guidelines? Well, I think every hospital can do this. And in every guideline we put out, there's probably an opportunity to have a penicillin allergy section. And this is, for example, the surgical prophylaxis guidelines that we have at the Austin now in every theatre, on every wall. And it's based upon TG, probably going to need a change after the new TG. But we've put in a box particularly about beta-lactam allergies, and again, breaking them up into immediate delayed and severe and non-severe. I think it's an easy and nice distinction. But you can therefore incorporate that, and particularly in a surgical setting, I think we would drive a lot of our vancomycin use away from that and towards back towards cefazolin. The other one is particularly in high risk, high usage populations, for example, heme. So all heme patients that are being elective admitted now, their antibiotic choice is discussed before they come in, and we preset their antibiotic prescribing and pre-chart that so nurses can give that. It has meant that we've been able to put a lot of people back onto tazocin or cefepime away from Ciprovanc or Astrinambanc, particularly in the allergy setting. So there's this opportunity here. And again, if you're building a business case, it's an opportunity to say, well, we're going to integrate this into all our clinical guidelines. The other one is to, again, we talk about low-hanging fruit. There's no more low-hanging fruit than this group. It's massive. So addressing the non-immune mediated antibiotic allergy is huge. So 20% of reported antibiotic allergies will in fact be type A. But what I mean by that is a non-immune mediated nausea, vomiting, diarrhea, headache, dizziness, generally unwell, itch without rash. You can name a million of them. And patients will make up a huge report of those. The other huge issue is this mismatch. So we went and asked all patients in a cohort of GenMed patients that were not confused and not demented what their penicillin allergy was, and looked at the record, and there's like a 25% mismatch. So half the stuff written in the record is wrong anyway. So two things that we have done, and we've got some brilliant support here. Misha Devchan is our AMS pharmacist at the Austin, and Belinda is our ID nurse at Peter Mac. We've just developed a simple AMS allergy round, which could really be embedded in any allergy ward service or any allergy post-prescription round, effectively trying to find all those patients with an allergy that have been prescribed an antibiotic and focusing on these type A in particular and this allergy mismatch. And part of that is using now this validated tool. So this tool is about to be published. We validated that in a group of nurses, doctors, and pharmacists about trying to risk stratify these people in a simple way that we could update the record. And I think it will hang low-hanging fruit. So I'm just going to show it quickly. It breaks things up into simple classifications, which I think everybody can use, like where was the rash? Was it a skin? Did it involve your blood counts? Did it involve your kidney function? And again, this traffic light system. For example, childhood exanthem, unlikely to be significant, non-severe. That could be re-challenged if you had a program as such. Here, rash and mucosal ulceration, and we've got layman terms, mouth, eye, or genital ulcers. We avoid that. That's red. That goes to clinic, and we don't re-challenge those people. We don't test those people. So this kind of traffic light system, and when in the hands of a pharmacist, the sensitivity and specificity of this was about 99%. The worst was actually the junior medical doctor. So the junior medical doctor is the worst person, but the pharmacist and the nurse were able to utilise this tool, and we utilised it in a cohort of patients that I'd tested in clinic. We knew their phenotype were actually very, very good. So this paper will come out soon. So the other thing you might think about doing is, well, what about a low-risk penicillin allergy program? How can we do that? We don't have skin testing. We don't have a facility to refer. How can we capture that and incorporate that in our AMS program? So we've done this at the Austin and Peter Mac, exactly the same protocol, trying to capture people with low-risk penicillin allergies that are adults, and they have a very clear criteria. It's an unknown reaction more than 10 years ago. It's a type A adverse drug reaction that the patient will not let you remove without a test dose. And then a history of benign childhood rash. And there's increasing evidence of this being safe, particularly in the US literature. This is a clinical protocol that we introduced. They do not need to be acutely receiving a beta-lactam. And the inclusion criteria, as mentioned, was age, and we're focusing on that penicillin and aminopenicillin. What I mean by that is amoxicillin and ampicillin. So just looking at our data, recently we submitted for an abstract. There were 46 patients, 23 cancer, 23 non-cancer. We haven't had a single adverse event, and 88% have been able to utilise a narrow spectrum beta-lactam post-testing. So I think we could keep collecting data. The number's going to be roughly the same. But I think as a pilot study, it shows what you can do with it's a simple protocol with a very neat and a regimented criteria. So I'm going to stop there, but hopefully I've shown that there is a large burden of antibiotic allergy in Australian healthcare. It significantly impacts on our key AMS endpoints and patient outcomes. Antibiotic allergy testing aids delivery of these key AMS targets. We need a lot more work in the health economic space, outpatient community data, and hospital outcome data in an Australian setting. And there's certainly opportunities to incorporate antibiotic allergy testing to AMS to support both our therapeutic guidelines and also our national standards. So I'm going to plug the Stewardship Forum. We're going to be talking about antibiotic allergies there, particularly in higher risk populations. If you are coming down for the forum, why don't you stay an extra day and come to the antibiotic allergy workshop. If you're a pharmacist that's been accredited for CPD points and it's been endorsed by ACID, we'd love to have you there. And if you've got any questions along the way about how you might want to implement it in your health service, very happy to share, and you can contact us via a number of platforms. So thanks very much. To do questions.
Thanks, Jason. With your allergy rounds, how often do you do it, and how long does it take, and how many patients do you see?
Great question. Great question. So Misha's doing this as part of her masters with Monash. So we do it once a week. We think once a week is a good starting point because there's a lot of overlap. A lot of those patients will be in for that time. We do it midweek. It takes us an hour. There's 3 of us on the round though. There's myself or another ID physician, the AMS pharmacist, and my allergy nurse comes as well. Now, I think the role of nursing is huge, and it's our starting point to try and integrate nurses into our AMS service. So it's quite feasible and quite practical. The other thing for us is why it's easy. Cerner generates a list for us once a week, which is great. So the EMR platform going forward is a real opportunity for this. It just literally picks off all those with an allergy that are receiving a restricted antibiotic. We go and see them. Half our impacts are nothing to do with allergy. It's picking up the ceftriaxone that shouldn't be on anyway. The VAC should never have been charted. So with the inadvertent impact has been just general AMS principles, which have been great. Yeah.
So thanks for a great talk. I'm interested in learning a little bit more about your view. If we look at our PBS and our MAX data, the penicillin people are using amoxicillin, and the cephalosporin they're using is Keflex.
Yep.
And this whole question about the amoxicillin Keflex cross-reactivity, which we've not really paid attention to, and you know, the commonest drug somebody who says they're penicillin allergic has probably had amoxicillin, and the commonest drug we tend to recommend is Keflex in that situation. And
completely agree.
Totally we're not really seeing reactions.
Yeah.
So I have some concern that
Yeah, sure. No, good point. So I think it's a strong message, and the anecdote comes to my clinic. So we see lots of people now. Probably the most common anaphylaxis drug is Keflex, probably because of usage. And when I test those patients, more than 80% will light up to amoxicillin on that skin test. So the biological plausibility is very strong, and the clinical thing is real. But I think we can get away with Keflex in a lot of situations because the patients don't have an allergy in the first place, or they've outgrown it. So where I think we should drive people away from using that is in the high risk group. So in patients with IG-mediated allergy, we shouldn't really use Keflex if they've had an amoxil allergy. I think that's still unsafe.
How common is that? And you said it does it on collection of welts. I mean, again, that's not a reaction I give people.
Yeah. So urticaria, where somebody says, I had a mild urticarial rash, it was just on my stomach or just on my hands, is a very common description when they come to clinic. So I think, or I got a rash in childhood, it might have been raised or it might have been flat. They're the ones that are probably in the mild, and we could maybe consider it. I think we still have to be careful though, because there's going to be, we see them all the time. The patient that was given amoxil had an allergy 5 years ago. The GP gave Keflex and they had anaphylaxis. This does happen in the community. I don't think we'll drive everybody to restricted antibiotics if we just focus on making sure we phenotype those people as severe, because those severe people will be very rare. Most of them will fit into that non-severe group. Like, for example, and we're going to revise this group. Yes. This, yeah. Yeah.
A lot of us, a lot of junior doctors, a lot of GPs are going to think, oh, it could be that.
Yeah, but the key word here is immediate rash. Yeah, yeah.
This is where I think some of us are feeling a little bit.
Yeah, yeah.
And how we can implement this in a way that
Yeah. I mean, it's interesting because we were trying to be conservative here, because we think the other way would be if we undo this and relaxed, and we have a case of anaphylaxis because somebody gave Keflex to an amoxil patient that had a history of potentially welts, well, that's also a problem as well. So it's a double-edged sword. I still think these are rare. This is the group that most will fit in, that we will be able to give Keflex in.
So just on that, if you do the clinic testing and all that sort of thing, usually you have material that you give to the patients to say, you know, if they've always thought they had an allergy, you do testing and you work out that they don't, or that they fit into one of those groups, or that you think they do, you give them material that you give them to take away. Yeah,
so we're fanatical about documentation. So the patient's GP, prescribers, adverse drug reaction committee, every hospital they visited get a letter, and it always fits on an A4 piece they can keep with them all the time. So, yeah. Okay. Thanks.
Thank you very much, Jason, for that excellent talk on allergies. Makes our life somewhat bit easier, hopefully moving towards future with our allergy desensitization programs. But our next talk is from Kirsten Bailey, one of our NCAS research fellows in the veterinary stream, and she'll be looking at the challenges of improving veterinary antimicrobial use. And thank you, Kirsten.
Okay. Today I'm going to give a bit of an update on some of the topics covered at Science Week, which is a conference run by the Australian and New Zealand College of Veterinary Scientists. This is the body through which veterinarians in Australia can pursue specialisation qualifications. It was quite refreshing to look at the program and see a whole lot of talks on antimicrobial stewardship and resistance. And I've just put a selection of them up there. You'll notice that Pierre-Louis Toutain features for a lot of the talks. He is a veterinary pharmacologist, and there's just a couple of other little sort of abstract type presentations which I'll cover a couple of. Just a disclaimer to start with, I'm not a pharmacologist, so it was a very pharmacology intense program, and so I've done my best to deal with the pharmacological side of things, but I apologise to all the pharmacologists in the audience if I've slightly misconstrued things. I guess as a veterinarian, I guess want to highlight that it's any use of antimicrobial drugs that can promote AMR, not only overuse, not or misuse, and it's used by humans and animals, and also in the environment. One of the speakers at the conference was talking about environmental impact, and I was aghast to discover how many antibiotics are used in the United States in plant agriculture. Fortunately, there's none registered for use in Australia, but they're tipping tons of it on their crops, which is just scary. Anyway, moving along. So Professor Toutain talked about 3 types of antimicrobial resistance that is important, well, in veterinary medicine. And so one is resistance in the target pathogen in animals. And so he thought that the resistance in these animal pathogens is really a risk to animals, as these particular pathogens are not zoonotic to humans, and so a relatively small risk. He then also talked about zoonotic resistance. And again, this would be more an individual health issue for humans. In comparison to the big issue, in his opinion, is the effect of antimicrobial drugs in veterinary medicine on the commensal microbiota. And that this is where there's likely to be the most transition of resistance from animals to humans. And some of his theory behind this is that if you're looking at the pathogen, the biomass of the pathogen in the site of infection, say the lungs, is going to be milligrams. Whereas if you look at the biomass of organisms in the digestive tract of a cow, it's going to be kilograms. And then when all that is then being passed out into the environment in manure, and then the way the manure is handled ends up in sludge and waste. And so then we've got tons. And sometimes the antibiotics are persisting in the environment. We've also got all the potential resistance genes in the microbiota that can transfer between different bacteria. And so this is the main area of risk. So in view of that, there was a lot of talk about what is the optimal antimicrobial treatment dosing regime in animals. And so it's really a balance between maximising clinical efficacy while also minimising for selection of resistance. And when we're talking about minimising selection of resistance, it's resistance of the target organism causing the infection, but also the effect we're having on the commensal microbiota. And if we can minimise that effect, then we can hopefully reduce the transmission of resistance via the food chain. So how are veterinary antimicrobial drugs contributing to effects on the commensal microbiota? The route of administration can have an effect. Oral route tends to be worse than parental. There are quite a lot of the veterinary antimicrobials used have very poor bioavailability. For example, oxytetracycline is only about 5% bioavailability. So if this is given orally, we've got about 95% that's just transiting through the gut and potentially infecting the microbiota. And ampicillin, also another commonly used drug in pigs, also has a low bioavailability. But also if we give these parentally, they can still be, and particularly the quinolones, the macrolides and the tetracyclines that are excreted through the gastrointestinal tract can be having an effect on the commensal microbiota. Also the water solubility of the drug. Lipophilic drugs tend to have more of an effect than hydrophilic drugs. And in veterinary medicine, we like lipophilic drugs because it means that the drug has a longer half-life, and so we can dose the animals less frequently, which when you're trying to medicate free-range beef cattle, for example, you don't want to have to be handling them too frequently. So that is an appeal for us, but then it has, and so that is a challenge facing the formulation of veterinary medications. Other things affecting the effect on the microbiota are the spectrum of the drug. A broad spectrum is obviously worse than a narrow spectrum. The challenge we face is at the point of clinical consultation is knowing what type of organism we've got, and so trying to select a narrow spectrum drug. Also the duration of treatment. The longer the duration, there's a greater risk of an effect on the commensal microbiota. So trying to avoid treatment longer than 5 days. And I think this has already occurred in human medicine about stopping the message that you must finish the course, and that we need to progress that way in veterinary medicine as well. They did mention a couple of strategies that are being researched to reduce the impact of the antimicrobial drugs on commensal microbiota, and these are 2 papers from humans. One is the use of some sort of product that traps the free antibiotic in the gastrointestinal drug to prevent it from having an effect there, and that's an activated charcoal product. And also there has been oral administration of a beta-lactamase concurrently with an intravenous beta-lactam antibiotic to degrade any excess antibiotic that is excreted through the intestinal tract. So what are some other things that we need to consider in our optimal antimicrobial treatment? We need to look at the right time of administration, and this depends a bit, well, depends quite a lot actually on the type of infection we're talking about. I think particularly in livestock, there's a perception that mass medication is driving antimicrobial resistance, and that we want to avoid prophylaxis, which is this area here in the green, where we're treating before there's actually any pathogen exposure, versus metaphylaxis, where we're treating early in the clinical infection before we reach the maximum expression of clinical signs. And one thing that they were discussing was the amount of pathogen that's there. And so our traditional approach to antimicrobial stewardship in veterinary medicine is to reduce mass medication. However, they've put forward a case for, if you do identify the fact that there is an infection there, early treatment is better than late treatment, because you're treating this much pathogen rather than this much pathogen. And so you may need a lower dose for a shorter duration than treating later on. And so there's quite a number of studies that have identified this, mainly using models of pneumonia, which, because pneumonia in calves is a big issue in feedlot cattle, and showing that 10-fold lower doses, if given earlier for a short duration, can create rapid elimination of all the bacteria. I guess the question is, what effect is this having on the antimicrobial resistance in the gut microflora? There was one study where they inoculated some germ-free rats with a resistant E. coli, and then induced a model of pneumonia with Klebsiella, and they had a low inoculum that was representing an early infection and a high inoculum representing the later stage of infection, and then they treated with 2 doses of cefquinone for 4 days, and they were able to show that the early treatment at the low dose had minimal or negligible effect on the expression or amplification of the resistant E. coli, whereas the later treatment at the higher dose had a much bigger effect. much more amplification of resistant population. So perhaps this is a case for early treatment. The challenges are the clinical application of this, being able to tell in the natural infection what stage the animal is at, so that we don't just end up treating all animals. So ideally, we want to be able to selectively detect animals during the early stage of infection. And we're limited by the imprecision of clinical diagnosis. However, there may be some future possibilities, and one of them is the Chinese have developed this face recognition software for pigs, and apparently they can even recognize chickens. I'm not quite sure how you then administer the medication just to the one chicken in the shed of however many thousand, but I guess that's the next step. And there was some talk about, I guess, to try and institute some rules around metaphylactic treatment is to develop some cutoffs. And so they suggested that maybe 15% of pigs need to be affected with, say, diarrhea before an antimicrobial treatment was indicated, which probably needs more work. So other things that affecting the optimal dosing regimen that are challenging us are that we really have limited data or no data on the optimal duration of treatment. And certainly it seems in human medicine that treatments are becoming shorter for a number of conditions if they are actually treated with antibiotics. And there's some evidence starting to trickle out in the veterinary literature. So a short duration of trimethoprim and sulfonamide treatment in female dogs with urinary tract infection. And then in combination with this is trying to figure out when, when have we achieved success or when have we achieved failure. And ideally we'd stop as soon as the animal's defense system can control the infection. However, it's a bit trickier because you're really reliant on the owner or the farmer's perception of when they've improved. So this is still a challenge. Current dose regimens are really only determined to select one effective dose, and they're not without minimising AMR selection. And it's generally a one dose fits all type of approach, which if we consider the metaphylaxis story I've just said, it would be nice to have an early low dose and a high dose. The regulators are not too keen on having two doses on the packet, and I can see how that is a concern with veterinarians interpreting which dose to use. But the one dose fits all approach isn't exactly ideal either. Another problem with the current dose regimens is that they've often been determined by studies in healthy animals, and so the pharmacokinetics may be different in animals in disease, and so that, as well as there's a whole lot of other factors that need to be considered, like the age of the animal, that whether they're lactating or pregnant, food and environment. And it seems in human medicine they've moved away from just looking studies in healthy animals, healthy people, to population studies, as well as the use of therapeutic monitoring. And this informs all those variables that can occur out in the real population rather than in just using a small population of clinically healthy animals. Some of the other challenges in determining this optimal dose, there's a whole range of different species. And even if you think about dogs, beagle dogs tend to be used to represent dogs, but there's more than 300 dog breeds. And there has been studies looking at glomerular filtration rate and whether there's a linear association with body weight. And while there is a general trend, there's also a lot of variation. So there's, I guess, a lot of, not quite species, but the breed effect to contend with, as well as just the whole range of species. And then the different ages within the same species. So with our ruminants, pre-ruminants versus adults, and there can be changes in the ampicillin bioavailability dependent on the age of the animal. And often that generalizations or extrapolation are not possible from one species to another. So each drug requires species by species investigation. So moving away from, well, I guess this follows on from our optimal dosing, is antimicrobial susceptibility testing, and how well does in vitro testing correlate with in vivo efficacy. And this was just a paper from the human literature showing that drugs classed as sensitive resulted in a 90 to 94% cure rate, but the resistant, even if resistance was present, they still resulted in a 60% cure rate. And so I'm not saying that this is a black and white situation, but just that this is another challenge in interpreting results. And that for a lot of veterinary infections, we lack species or disease specific breakpoints, which leads to empirical treatment. And a couple of examples are Lawsonia intracellularis and Brachyspira in pigs, which are extremely difficult to culture, and so that is a challenge. And then mastitis in cattle, their susceptibility testing doesn't necessarily relate to clinical outcomes. One other area that was highlighted was that when we're doing MICs, we're determining, we're looking in a non-biological growth media, and that sometimes this can affect the MIC and how well it represents a biological fluid. And an example was that macrolides, the maximal plasma concentration that could be achieved was well below the MIC, but they seemed to be clinically effective. And so a whole lot of studies were trying to figure out if there was something else going on. But then if you do the MIC in serum, the MIC is a lot lower. And so perhaps this is the explanation. And similar thing has been shown with marbafloxacin, but it's not all antibiotics and it's not all bacteria, tetracyclines, it can be the other way around. So this is just another important consideration when using MIC data to predict dosages for clinical use. So that's the end of the pharmacology part of it. This was just a presentation by Julian D'Andrio, who's from University of Melbourne out at Werribee, talking about chronic enteropathy and the fecal transplant versus antibiotic therapy. So chronic enteropathy in dogs is, the treatment approach is stepwise. They start with a diet trial, and greater than 50% of animals will respond to diet modification. But if they don't, then the next step is an antibiotic response trial. And the three drugs that are most commonly used are oxytetracycline, tylosin, and metronidazole. And some animals respond really quickly and then they're fine, but other animals relapse as soon as they're removed from treatment and so need long-term treatment. And then if they don't respond to antibiotics at all, then they move on to the immunosuppressant treatment, which may or may not work as well. And so I guess obviously there's concern over long-term antibiotic treatment and the effect it's having on resistance. And they're not really sure of what role the antibiotic is playing in these dogs in cases of chronic enteropathy. Is it the modification of the gut flora, or is it some other immunomodulation? So they've started doing a dysbiosis index, so samples are sent off to Texas A&M University, and it costs $170 Australian to perform the test. And they've compared the taxa between healthy and chronic enteropathy dogs. It's not specific for causality, so there are a whole bunch of other things that can alter the microbiome to look like dysbiosis, but it's a tool for veterinarians to use. And then using this information, they've started using fecal transplant as an alternative to antibiotics, which is being used in people with Clostridium difficile colitis. There's still uncertainty around donor selection criteria. A lot of the criteria have just been extrapolated from human medicine, and I believe in human medicine there's still a lot of uncertainty around donor selection as well. Obviously, you want them to be fairly healthy, not have any gastrointestinal issues, no antibiotics in the last 3 months, and they perform a dysbiosis index on the donor. And then the receiver is fasted overnight, sedated, and the transplant is delivered per rectum. And there is a study from Weiss et al. That showed puppies with parvovirus had a faster resolution of their diarrhea when they were treated with a fecal transplant. So it's a fecal transplant's not a new therapy, but is a new therapy in dogs, so we'll see where this goes. And then one other presentation that I thought might be of interest was Leah Toombs-Ruan from New Zealand was exploring pet ownership as a risk factor for ESBL infection in humans. So in New Zealand, prior to 2011, they had very low rates of ESBL, and then they've had an increase. And in New Zealand, greater than 60% of homes have pets. So they did a prospective case control study where they enrolled people with community-acquired UTI caused by an ESBL or an AMP-C beta-lactamase producing Enterobacteria ACA. And then they used randomized dialing to select controls. And then from that population, they asked if people could provide fecal samples and their animals could provide fecal samples. And you can see that the numbers dropped off dramatically. So they got samples from 27 case households, and those samples were then whole genome sequencing of ESBL or AMP-C isolates was performed on urine and fecal isolates. And the results were that 3 out of the 27 households had a dog carrying an ESBL E. coli in the same household as a human carrying one. And that 2 of those 3 households, it was the same MLST type in the dog and the human. So their conclusion was that pets were not a risk for human ESBL or AMP-C producing Enterobacteria ACA, although they did comment that most of the strains were human type strains that they did detect, and that essentially the pet is just another member of the household, and so they're just sharing bacteria around, and so the animals could be carrying it, and so could play a role in transmission, but that they couldn't determine direction of transmission. And that's all I have. So thank you. Are there any questions?